This video aims to identify thoracic landmarks for pulmonary evaluation, examination of the anterior and posterior thorax using visual inspection. This is the first step of the examination and a very important part of the exam, since many abnormalities can be detected by merely inspecting the thorax as the patient is breathing. In this video, the examiner will assess a healthy patient, but keep in mind that the other patients may have the same normal findings or may display normal variations or abnormal findings. General approach prior to examination. Introduce yourself and state your purpose and ask for consent. Adequately expose area to be examined. Then strip the patient to the waist and use a bib or towel to cover a woman's breast if your patient is a female.
Good morning, I'm Dr. Orlie Cunanan. What's your name?
Hello, Doc. My name is Erwin Ken, Parchaso.
Okay, have a seat.
Thank you.
So, Sir Erwin, I'm here to examine your thorax and lungs. Is it okay for you to undress so that I can thoroughly examine your thorax region?
Yes, it's okay.
Upon examining the anterior thorax, ask the patient to maintain sitting position with both arms behind, or ask the patient to lie down, especially in women, since the breast will be likely to get in the way.
Sir, can you move your hands behind so that I can thoroughly know?
Begin the examination with a brief survey of the patient's chest and respiration. Observe the rate, rhythm, depth, and effort of breathing, and listen to the sound of his breathing. Normally, a resting adult breathes easily, quietly, and regularly, about 14 to 20 times a minute. Upon a thorough inspection, we'll be able to identify and point out the following landmarks, which are your suprasternal notch, manubrium of sternum, sternal angle, body of sternum, xiphoid process, the second rib and its interspace and costal cartilage, and the costochondral junctions. Place your finger in the hollow curve of the suprasternal notch, then move it down approximately 5 cm to the horizontal bony ridge where the manubrium joins the body of the sternum, called the sternal angle or the angle of Louis. Directly adjacent to the sternal angle is the second rib and its costal cartilage. From here, using 2 fingers, walk down the interspaces on an oblique line. Take note that the ribs at the lower edge of the sternum may be too close together to count correctly. To count the intercostal spaces in a woman, displace the breast laterally or palpate more medially. Avoid pressing too hard on the tender breast tissues. Next up is the posterior part of the thorax. The 12th rib is a starting point for counting ribs and intercostal spaces and provides an alternative to the anterior approach. With the fingers of one hand, press in and up against the lower border of the 12th rib, then walk up the intercostal spaces. The inferior tip of the scapula is another useful bony landmark. It usually lies at the level of the 7th rib or interspace. The spinous process of the vertebra are useful landmarks. When the neck is flexed forward, the most protruding process is usually the vertebra of C7. If 2 processes are equally prominent, they are C7 and T1. You can often palpate and count the processes below them, especially when the spine is flexed. Next is we'll check on the circumference of the chest. Visualize a series of vertical lines. The midsternal and vertebral lines are easily demarcated and reproducible. The midclavicular line drops vertically from the midpoint of the clavicle. To find it, accurately identify both ends of the clavicle. The anterior and posterior axillary lines drop vertically from the anterior and posterior axillary folds, where the muscle masses that border the axilla. The mid-axillary line drops from the apex of the axilla. Going back to your posterior part, the vertebral line overlies the spinous process of the vertebrae. while the scapular line drops from the inferior angle of the scapula. Now we'll talk about the trachea and major bronchi. Breath sounds over the trachea and bronchi have harsher quality than those over the denser lung parenchyma. The trachea bifurcates into its main stem bronchi at the levels of the sternal angle anteriorly and the T4 spinous process posteriorly. The right main bronchus is wider, shorter, and more vertical than the left main bronchus and directly enters the hilum of the lung. The left main bronchus extends inferior-laterally from below the aortic arc and anterior to the esophagus and the thoracic aorta, and then enters the lung hilum. Each main bronchus then divides into lobar, then into segmental bronchi and bronchioles, terminating in the sac-like pulmonary alveoli where gas exchange occurs. Lastly, we will identify the accessory muscles in the neck, which are your sternal and clavicular head of the sternocleidomastoid muscle and your scalene muscles.